All right, welcome to the Explainer. Today we're opening up a case file that's, well, it's pretty critical for every psychiatrist out there. We're going to be building our argument based on a really important systematic review by Dr. Lars Kessing, which takes a hard look at the long-term course of bipolar disorder.
So here's the big question, right? Does bipolar disorder actually get worse over time? It's a belief that's pretty common in clinical circles, but it's also been challenged here and there. So today, we're going to bypass the opinions and go straight to the evidence to see what decades of research really tell us.
So here's our game plan. We'll kick things off by defining what progression even means in this context. Then we'll dig into the evidence on recurrence, how episodes might change, and the long-term stuff like cognitive decline. And to wrap it all up, we'll piece it together to understand what it all means for us in the clinic.
Okay, so first things first. What are we actually talking about when we use the word progressive for an illness like this? Let's get our terms. This is the core idea right here. It's not just about the clock ticking. It's about the impact of the episodes themselves. The central theory is that each episode can leave behind a kind of biological scar, which then fundamentally changes the future course of the illness. So to really put that hypothesis to the test, the review looks at these 5 specific measurable things. Does the risk of another episode go up? Do the episodes themselves get longer or more severe? Does it take less of a push to trigger one? And the big one, what happens to a person's cognition in the long run? Let's start building the case. Our first piece of evidence, let's call it Exhibit A, gets right to the most studied question of all: recurrence. After you've had one episode, what's the real risk of having another? This is the top-line finding, plain and simple. It's a clear statement, but it is so crucial to remember that this describes the average path. Of course, the course is heterogeneous, every patient is different, but the general trend, the one supported by the strongest evidence we have, points towards progression. And the evidence for this is it's powerful. This number, nearly 3,000, that's not the total of all the patients in the review. No, that's the sample size from just one key study, a Danish nationwide register study. When you can follow that many people for up to 23 years, well, the findings carry some serious weight. And this table is where you really see the weight of the evidence stack up. Out of 38 studies, a solid majority, 25 of them, found a worsening course. But here's the real kicker. Check out that second line. When you isolate just the studies that used more sophisticated stats, what's called survival analysis, the signal gets even stronger. 5 out of 7 of those more robust studies confirm it. The time to the next recurrence gets shorter. Now, as clinicians who need to evaluate evidence, it's really important to get this methodological point. There's this statistical trap called Slater's fallacy. It can basically create an illusion of progression just because if a patient has more episodes in the same amount of time, the gaps between them have to get shorter. It's just math. But modern survival analyses, that's the fix. They correct for this, and they also correct for the fact that some people are just more prone to recurrence to begin with. The best studies use these methods, and that's what makes their conclusions so convincing.
Okay, so we know the risk of another episode goes up. But what about the episodes themselves? Do they get longer? Do they get more severe?
This is such a fascinating finding from a historical perspective. The data shows this clear line in the sand. Before the 1940s, before we had ECT, lithium, and modern psych meds, studies pretty consistently found that episodes got longer over time. After the 1950s, that pattern just disappears. I mean, this is a huge win for modern psychiatry. It suggests that while we may not be stopping the recurrence risk completely, our treatments are really effective at stopping this specific type of worsening. Now, the evidence on severity is a little bit more limited, and the review is upfront about that. A lot of it comes from research on unipolar depression. However, the data that does exist for bipolar disorder all points in the same direction. Later episodes tend to be more severe, symptomatically speaking. It suggests that without intervention, the illness just hits harder and harder each time.
Okay, now we turn to some of the most, sobering long-term consequences. Let's look at what it takes to trigger an episode and the ultimate impact on a person's cognitive function. This really supports a kindling-like model. Those first few episodes, you can often trace them back to a big life event, a major stressor. But as the illness goes on, it seems like the brain becomes sensitized. The illness starts to take on a life of its own. and later episodes can pop up with little or even no obvious external trigger. The threshold for getting sick just gets lower.
This is a powerful statement taken directly from the review. It makes a direct link that, frankly, many other reviews on neuroprogression have kind of missed. It totally reframes the conversation away from subtle changes on neuropsych tests and toward the most clinically significant cognitive outcome you can imagine.
And we're not just talking about a theoretical end stage here. The data is stark. This number is the odds ratio from a meta-analysis that's cited in the review. It means that having a diagnosis of bipolar disorder is associated with a nearly threefold increased risk of eventually developing dementia. That's a profound risk, and it's right at the center of the whole argument for progression.
This slide helps clear up a really common point of confusion you see in the literature. Why do so many short-term studies say they don't find progressive cognitive decline? Well, the review suggests it's a matter of timescale. Following patients for just a few years might not be enough to detect a very slow, gradual decline. But when you look at the ultimate outcome over decades, a clinical diagnosis of dementia, the progressive nature of the risk becomes crystal clear.
So, we've reviewed the evidence on recurrence, episodes, triggers, and cognition. What's the final verdict from our case file? And, most importantly, why does this matter to us clinically?
Here it is. This is the key takeaway. It is not an absolute rule for every single patient. The course is variable. But when we look at the data from thousands of patients from the best designed studies, the average course is one of worsening over time across several critical domains. This has to be our evidence-based expectation.
So let's just put it all together. You can see the story this evidence tells. Each episode increases the risk of the next. Those episodes tend to get more severe, while the threshold to trigger them gets lower. And this cumulative burden, this scarring over time, leads to the most significant long-term consequence, a substantially increased risk of dementia. That is the average, untreated path.
This is maybe the most critical and honestly the most humbling conclusion from the review for us as clinicians. We saw that treatment can stop episodes from getting longer, and that's a huge success. But even with our best current treatments, we are not stopping the fundamental increase in recurrence risk. It just underscores the urgent need for early, aggressive, and sustained intervention.
And we'll end with this question because it's directed at you. This evidence isn't just academic, it is a clinical call to action. Understanding that the average course is progressive completely changes the conversation about treatment adherence, about early intervention, and about our long-term goals. The evidence defines the challenge. Our clinical skill is what can change that trajectory, one patient at a time.